But I don't want to hold up proceedings any longer. I would like to introduce our keynote speaker, Professor Popat, tonight. And for those of you that don't know him and haven't had the benefit of hearing him speak before, Professor Popat is based at the Royal Marsden, and as he is our honorary clinical advisor for the charity, but also he's one of the leading ALK experts across the UK. So we really do have the best of the best with us this evening. So I'm not going to say any more. I'm going to let Professor Popat do the rest. So would you like to come to the stage? Thank you very much indeed.
Right, well, good evening, everyone. It's really wonderful to be here, and a great privilege to be before you. Deborah, before we were talking about the first meeting that we had here. It was around the corner. I can't remember which hotel it was. About 5 years or so ago, and nearly 17 or so people in the room. I didn't even know there were 17 outpatients, in the UK at that point. And, it was a great, I think you said to me, will you pop over for about half an hour or something like that? And then we ended up there for a couple of hours or something, having a chat about various things. And from that, you've grown this amazing organisation where actually it's not just a group of individuals. I like to think of the organisation as a family in many respects, because we all know and love one another in many different ways, and all of us have a common theme, which is to try and do the best that we can for the situation that we find ourselves in. But all of you and all of us, myself included, are actually incredibly lucky. Now, I didn't feel lucky this morning when Mrs. P finally admitted that she'd caused the dent in the car, that I was wondering where that came from. But actually, in many respects, we are actually quite lucky in where we are. And we're lucky because we are, each and every one of us, living history. We're living history because we're here around the biology of something called ALK Positive lung cancer. This is a novel disease. It's not been around for long at all. In fact, we have to be very, very grateful to our Japanese colleagues. Now, I'm very grateful to my Japanese colleagues for many reasons. We have the Sony Walkman, which famed my youth. We've got, they gave us VHS and Betamax, the great wars that we had in the day. And even Ninja Warrior, which some of you will know what I'm talking about. But actually, the Japanese were fundamentally behind the discovery of the abnormal ALK protein back in 2007, it was, when Dr. Soda and colleagues published their first paper, which demonstrated that if you take a normal ALK protein and make it abnormal, it causes lung cancer. And actually, we are walking in the footsteps of really great people, actually all of us here, because we're walking in the footsteps of people who have given their time, their generosity, and their bodies to help other people. And Dr. Soda and his colleagues actually discovered the abnormal ALK protein by analysing the DNA of the cells of a Japanese patient who actually had smoked a reasonable amount in their lifetime. And only through the generosity and gift that each of us do in our small ways that we do in our life, do we advance science and do we advance research and make an impact on how we move the field of medicine further. But we are lucky because we've come such a long way in how we treat cancer. The disease was only identified in 2007. I mean, I was still grey-haired then. I'm even more grey-haired now, but at least I've got some hair, so I should be grateful. And at that point, we didn't even know that there was such a thing called an ALK inhibitor. They just didn't even simply exist at that point. And then Pfizer, the large pharmaceutical company, came up with a very interesting drug. Well, it wasn't even a drug then, it was a chemical. It was called PFO234-1066. And it wasn't even designed to switch off a protein called ALK. It was designed to switch off something called MET. And it happened to switch off something called ALK at the same time. And to all the credit, they decided to test it in ALK positive patients, and it worked wonderfully. And PFO234-1066 then became called crizotinib and was the first licensed ALK inhibitor only 3 years after discovery of the disease that exists. I mean, that is an amazing pace of change. And I was lucky enough to experiment on patients that really gave their time, their generosity, to use this drug. And we were starting to see some phenomenal benefits with this amazing drug when we were treating a disease which was otherwise untreatable, specifically lung cancer. And then we fast forward a few years, and I was at a European meeting in, I can't remember what it was, I think it was in Copenhagen, and I was lucky enough to be the invited European expert to critique 3 data sets, not 1, not 2, but 3 data sets on 3 different ALK inhibitors that had been identified, synthesized, experimented on in human beings, and with novel data. One of those drugs wasn't even a drug then, it was a chemical. It's called LDK378. That went on to be called ceritinib. There was another drug called AP26113, and that went on to be called brigatinib. And there was another drug there which had data on, and that's called CH5424802. CH because it was manufactured by a company and developed by a company called Chugai. And Chugai are based in Japan. And that's another reason why we all have to be grateful for our Japanese colleagues, because that drug is now called alectinib. And many, many, many people around the world are on that. So we have to be very grateful, very thankful, and very lucky to be in the footsteps of people that very generously gave their time. And we have to recognize the huge benefit that research gives to all of us here. But since the time that we discovered this new disease, we've discovered many, many different things about this disease and how we treat people and how doctors learn and how we implement new technologies and new treatments into healthcare. We've had a number of lessons that we've learned over the years. I think when I look back and think about what is the most important thing I've learned over the years, it's actually that each and every one of you in this room are our greatest asset. Now, it may not feel like it, but actually patients and patients' caregivers are the most important people that we have in the community. Because actually nobody wants to listen to a grey-haired old fart like me speak. Well, I mean, some people do, but not everybody. Not Mrs. P anyway. But, you know, really when it comes to changing matters, it's what you as patients and it's what you as patient carers say that really makes a big difference. Because actually government will listen to what you say. They won't listen to 10 of us. Definitely won't, because they hear us talking all the time. But if you step up and say, listen, this is what we think should happen and it's not happening, people start listening. So it's really important that you make that change, and you have made that change. And Deborah, I want to congratulate you with everything that you've done with the organisation to be recognised by NICE and many other government agencies as an official partner in many different programmes that are on in government. So Deborah, a really round of applause for everything you've done. So not only are you the greatest asset, but you've done so many things for each other. You've supported each other. I mean, that is a huge bonus. We can't, as physicians and as nurses, we can't be here for everybody all the time. So we do rely on all of you taking your individual learnings and sharing them, happy and sad, with all of you. You've empowered yourself Look at all of us. We're here today. You've empowered yourself to learn more about the disease. And many of you are almost professional advocates in a walk of life. We've learnt a lot about this disease, and we've learnt some things which need shared learnings. And how do you discover a disease, learn how to treat it, implement new treatments over a period of time, and make sure that everybody is having that same treatment over a few years? It's next to impossible, isn't it? I mean, how do we share best practice? It's really hard. But we've learnt lots of things about the disease, and we've been able to share best practice. We've learnt about risks of blood clots. We've learnt about risks of brain disease. We've learnt about the risks of how we treat patients, how we manage our side effects. And actually, we've learnt that there are different types of ALK positive lung cancer. So what do I mean by that? So what we mean is that we're very lucky here because we've got lots of people here who are doing well. That's fantastic. But we should actually take a few seconds, or even longer perhaps, to reflect on people that have bad ALK disease, that don't do so well, have a very different biology to what was promised when they were told the diagnosis, and the disease didn't behave in that way. And we as physicians and scientists need to try and figure out what it is that makes one group of people on paper live so well and for so long, and another group of paper who look exactly the same on paper not do so well. And that's really what we as physician scientists are trying to do at the moment. One of the other third learnings that we have is we have to believe in research, because only through research will we afford change. And only through research have we effected change. The only reason that we have a huge organization now is through research. And believe me, research don't get funded well in the UK, let alone anywhere else. So we do need to make sure that we as physicians and you as advocates, patients and carers, are ensuring that the relevant agencies are funding research in your particular hospitals to make sure that that is ongoing at the pace that it needs to. After all, if you think back, we discovered ALK positive disease a few years ago. We only sequenced the human genome a few years before then. So the pace of change between implementing genomics, identifying a disease, treating that disease, and then developing next generation drugs to that disease is absolutely huge. But the fourth the fourth learning that I've developed over many years is don't believe everything you hear, quite surprisingly. Now, we sort of learnt that by watching our American colleagues and the battles that they've had across the pond. But there's a lot of fake news out there. And we have to be very careful that we only listen to reputable sources. The truth of the matter is we live in a great world of the internet. And isn't that fantastic? You know, we can disseminate information quickly, we can share our experience, but it also means that anybody can post anything. And we see a lot of that in politics. Isn't it awful how they fight with each other, how they say just lies and get away with it? But actually, we don't see lies in medicine, actually, but we don't hear all truths either. And so we have to be very careful with what we hear. And part of the problem that we have is that we as physicians are really keen to develop drugs and take a chemical and make it a drug quickly. And we as physicians who look after patients are really keen to make sure that this reaches patients, and patients clearly really want to be on the best drug possible. And that creates problems because industry need revenue to develop their drugs, and they need the investors to believe in their drugs. And so often what we hear in the news isn't necessarily reflected by what we see in routine clinical practice, because the news is not designed for patients, it's not designed for us as physicians, it's designed for the investors. So we have to be able to separate what the investors need and what we as physicians and what we as patients and patient advocates need to know. And that's really where this organisation comes in, because you know what Deborah's done is create a whole group of individuals that know the field well, know what's real, know what's not real, that can tell the difference between truth, non-truth, and help guide everyone in this room to what really is happening and what really may not be happening. But the one thing we need to think about is we can't be static. If we're static, we're not going to get anywhere. And in the world of medicine, we're not static. In the world anywhere, we're not static. I mean, for example, if you look at your mobile phone, wow, that's quite remarkable. Whoever did that, I need to use you again, actually. That's great. That's great. We need to work on that one. That's good. So if you take your mobile phone, the amount of technology we see in that mobile phone is really quite remarkable, isn't it? I mean, gone is the fax, gone is the paper, gone is the telephone. We're all just using one handheld gadget for everything. We weren't doing that 10 years ago, right? It was completely different. So what's going to happen in the next 10 years? The pace of technological change is absolutely massive. I can guarantee you that we will be in a totally different world from the medical viewpoint 10 years from now than where we are now. If you think what we've got now is amazing, wait till you see what's going to pop up out of the blue in 10 years. It's going to be absolutely amazing. We've got some amazing things happen. We've got these mutation-specific inhibitors being developed. They're great. Well, at least I hope they're great. We don't really know yet. And the one that I guess you're all here to hear about is NVL655, a chemical. We don't really know whether it's a drug yet. And my colleague Anna Mincham, I think, is going to go into some more details about that tomorrow. We're all waiting because at the beginning of October, we're going to hear the first data reveal about this drug. Is it any good? Who's it going to work in? What are the side effects like? We'll find out in October, and by the end of October, we'll have a better idea of where we're going with this particular drug. And at the end of October, so at the beginning of October, that's the triple meeting where the NVL655 data is being presented at. And in the middle of October, we've got a whole new disease being invented. And this is another ALK positive disease, a disease that we didn't know existed. And it's a disease called early ALK positive lung cancer. And this is a disease where patients have operable disease, and we never used to test them to see whether they're ALK positive or not. And we started testing them. We found a few people that are ALK positive, and we didn't know what to do with them. And in mid-October, we're going to see and listen to data about using alectinib in those patients to minimize the risk of relapse, which is going to revolutionize this field and is going to bring a whole different group of people into this organization. It's going to be great. But when it comes to using our medications, we've got lots of different things happening. For a start, we've been classifying our medicines as first generation, second generation, third generation. I mean, who's to say what generation it is, right? It's all marketing, isn't it, right? There's no classification of that, really. I like to think of it in a slightly different way, and I give my credit to my Californian colleague, Dr. Ignatius Wu, who some of you will know, some of you will have listened to speak. He's a great Californian ALK expert. And he wrote a paper saying that we should really think of our ALK inhibitors as those that are non-brain penetrant, such as crizotinib, and those that are brain penetrant. And those that are brain penetrant, we can then further classify into those that are mutation sensitive and those that are double mutation sensitive. And the NVL1 fits into the double mutation sensitive category. And I think we're going to have a lot more drugs being developed in that category over the next few years. And the reason that I know that is when I look at what's happening in drug development, there's a huge amount of drug development happening in China. And those Chinese drugs are being co-developed over time in many different fields in the West as well. And so the pace of change is going to continue. But where else are we going to go with the field of ALK positive lung cancer? So I think one of the things that we're learning more and more about is who are the good ALKs and who are the bad ALKs. That's not the individual, that's their disease. In whom can we get away with just a simple, straightforward tablet? And in whom do we need to escalate the treatment, where a simple, straightforward tablet is not going to be enough? We need to add in more treatments. We need to add other targeted therapies. We might even need to add in chemotherapy up front to get the maximum out of that. How are we going to fit in something called liquid biopsies, where we're taking a simple blood draw and analyzing genes? That's going to come into the future more and more as we figure out how we individualize patient strategies so we can dose escalate or dose de-escalate, treatment escalate, treatment de-escalate. And in the last 10 years, we've learned huge amounts about genomics. And in the next 10 years, we're going to learn even more about genomics. And that's going to hugely influence how we actually use our treatments in routine day-to-day practice. And when it comes to genomics, things are really quite different. Because if we think about genomics and we think about some creatures, for example, a caterpillar and a butterfly have exactly the same genes. Exactly the same genes, but they are completely different organisms when you look at them. So how do we relate to the changes that happen in these organisms to what's going on in cancer? We're going to learn a lot more about the fact that it's not just the genes that we're interested in, but what regulates the genes that determines how we best treat our patients. We also need to figure out, how do we live better? How do we live better when our drugs are perhaps getting more and more potent? And when you have more and more potency, we get more and more side effects. So how do we make that trade-off between having a more potent drug with more potent side effects, when I could have a slightly less potent drug with slightly less side effects and perhaps live slightly better? These are difficult decisions that we have to make. And I'm not sure that anybody knows the answer to some of these decisions. We may not have all the drugs that we need at this point, but clearly in the next few years, we probably will. These are great problems to have, frankly. 10 years ago, I couldn't even treat the disease. Now I'm trying to figure out which of the many options I'm going to use and when I'm going to use them. Isn't that fantastic? Isn't that a great position to be in? We have come such a long way in the treatment of cancer that all I can say is the future is incredibly, incredibly bright. I, for one, think that we are going to be in a very, very different place treating cancer in general in the next 10 years, and in ALK positive disease, absolutely. And with that, I'd like just to sum up and thank a few people. I want to thank all of you, actually, all of you for being really quite wonderful individuals for everything that you do. It's actually quite brave coming along to this type of meeting. You know, many of you will have been here and you won't necessarily know anybody. Many of you will know a few people. I'm really pleased that you're all here, because actually you're all individually making a huge difference. And when you put that together, that's a massive impact. So carry on all the great work. Your dedication is wonderful. And believe me, you are all trailblazers. And many people are looking at exactly what you're doing and trying to copy that. Isn't that wonderful? To be copied is one of the greatest compliments that you can actually receive. I'd like to thank the Board of Trustees for really keeping the organisation solvent, functioning very well. Your vision, your meaning, your purpose is wonderful. And actually, without the Board of Trustees and our new CEO, you wouldn't be making the difference that you are. And actually, the organisation is making such a huge difference every day. We see it in the clinic. It's just wonderful. And finally, to Deborah. Deborah, you're a wonderful chair. You're an astonishing, astonishing woman. And above all, you're a beacon of hope. And with that, I'd like to thank you very much for your attention. And I hope you found that of some interest. Thank you very much.